Hi, everybody. Thanks so much for joining us today. So today's panel, we'll be talking about resilience and robustness. The pandemic really showed us that healthcare systems across the world were tested in a pandemic scenario. So resilience and robustness is generally defined as a system's ability to return to its normal function after it's been disturbed or perturbed. With the pandemic, we saw that healthcare systems may not be as robust as we thought, especially in extreme situations and circumstances like surge demands. So with that, today's panel is going to explore how we can introduce more robustness into our healthcare systems. And we'll look at it through the lens of how we can use technology, engineering, data, and artificial intelligence to help make that work better. So we are very fortunate to be joined by an incredible panel of people. So we have Andrew, who is the founder and director of Vaccine Hunters Canada, Laura, a professor at the Dalla, Lana School of Public Health here at the University of Toronto, Mohammed, the vice president of data sciences and advanced analytics at St. Mike's Hospital, and Myrtede, a professor of mechanical and industrial engineering here at the University of Toronto. So thank you all for making the time to join us today. I appreciate it. And I'd like to start off with some framing questions. I want to get each of your perspective on something. What was the biggest thing that you learned from the pandemic, and what research is still needed? So I would like to start with Laura, if that's okay.
Yeah, that sounds great. Hi, everyone. Thank you so much for inviting me to be here. So many learnings in the pandemic, for sure. I'm going to focus on two. The first one is in how little we invest in data infrastructure and how that needed to be done decades ago, and how little the data infrastructure in this country and many countries were lacking. I kind of like to make the analogy of, we're flying a plane through a hurricane. We can't see, and we need the instruments on the plane and telling us what's going on. And essentially for us, especially at the start of this pandemic, it was blacked out. We didn't have answers to very basic questions like, how many cases are there, and who's affected, and what's our hospital capacity? It goes on and on and on. And it's not because of people, this is because of infrastructure, which didn't get invested in decades back. So we can talk a lot about that. Engineers have a big role to play there. The second piece that I would say is a big learning is data is necessary but not sufficient to make decisions. And I happened to be around during H1N1 doing epidemiologic work, and I did a study on how people use data and evidence to make public decisions in a public health emergency, and so many of those learnings still hold true today, in that it's a very complex process from data and analysis, which I love, to actually how the decisions get made. And actually, that's where we need to do a lot of more work. We need a lot more transparency, and there's a lot more of a role for visualizations and how we integrate data into decision making. So those are the two things I'll start with.
That's great, thank you. So Myrtede, I'd like to get your opinion on what did we learn and what research is still needed.
So I guess I'll start by building on Laura's point about infrastructure. You mentioned data not being necessary but not sufficient. I think our healthcare system in general is obviously necessary, but it was not sufficient. And so in both our works, Laura, we use the social determinants of health framework. And so I think we saw in terms of the frailty, some of the frailty we saw in our healthcare system was the result of poor social support systems, right? Where we had people who, for example, got sick and couldn't take the time off. And so they were getting other people sick, and that was putting pressure on our healthcare system. And so I think in addition to the actual physical infrastructure, our poor, and I should mention, I spent most of the pandemic in the US, and so our healthcare system is quite different than what it is in Canada. But kind of the limited access to healthcare, poor social support systems, put pressure on our healthcare system. And I think we see it outside of the pandemic, but it was exacerbated by by the pandemic. So that was definitely one of the lessons. And then because of our poor social support systems, certain populations were more vulnerable. And so, we saw those disparities that kind of underlie, different, our healthcare system in general, and access to care and quality of care also be exacerbated by the pandemic. So those were two of the lessons I think that kind of were front and center for me.
Thank you. And Mohammed, I'd like to hear what you have to say as well.
Sure, so a lot of great points made. I'm going to provide a little bit of a different perspective around like on the ground, on the floors in terms of the hospital environments and such, in terms of managing the pandemic. The first big thing that I think we had to learn was to be comfortable with uncertainty, and it relates to this whole point around infrastructure and data. That being said, if you build a nice data environment, it still can cause more harm than good. And the reason why I say that is because a pandemic is very, very dynamic, very multifactorial. It's as much dependent on how we react to the pandemic as the virus itself. And actually, I would argue it's even more dependent on how we react to it. How do we react to it? Social factors, political factors, all sorts of different factors that get us to move in a different direction in society, where governments impose lockdowns and we have schools saying to kids, stay home. All these sorts of things will contribute to how the pandemic plays out. We've been trying to be very data-driven with the lack of data that we have. But there's somebody who's fairly influential who told me, it was much better for us to be lucky than smart in this situation. Because when we have data, we're missing data on 10 other factors. And if we act on the data that we have, knowing all these gaps, we may actually be doing more harm than good. So one, being being comfortable with uncertainty. The other thing was to be nimble and practical. So what do I mean by that? There's several systematic reviews that are out there now. One that I read just a little while ago with over 400 studies looking at AI solutions for COVID. And when the investigators actually looked in to say how many of these solutions are actually deployable into clinical practice that can be used in a meaningful way, 0. Right? We weren't being practical. We were just putting out research that would never be used. That's not helpful. And so also realizing too that research is often a static process, and we've tried to adapt to make it a dynamic process, and I think that's the right way to go. Because the pandemic is dynamic, we don't know how many staff are going to be sick tomorrow and out, and they can't service so many patients. That's going to change every day. And being able to accommodate that uncertainty, that variability, becomes critical in terms of how we react to the pandemic. And data can play a big part, research can play a big part, but it has to adapt to that mindset of being nimble, practical, and thoughtful.
Great. So, Andrew, what are your thoughts on what did we learn and what research is still needed?
So I would say there are two important things, learnings from the pandemic. The first is the power of volunteerism. So today's volunteers at vaccine clinics, my team of volunteers in Vaccine Hunters Canada. Never underestimate the power of volunteers. And volunteers, they literally fill gaps. And the other point I want learning is being humble. So being open to learning from other people, and like I'm humbled to be sitting here today among such distinguished people. One story I want to share, if that's okay. So I was at a clinic to get my second dose, and my vaccine administrator was prepping the dose, and I haven't been outside the house in a long time, so I wanted to fill that awkward silence with something. So I took university stats, and considering we have 500,000 followers on social media, and considering he's in healthcare, I would think that the question I would ask is pretty rhetorical. So the question I asked was, have you heard of Vaccine Hunters Canada? And then he goes, no. Is that something I should be concerned about? It took me a second, but I realized that he thought I meant Vaccinator Hunters Canada. So, yeah, my bubble burst, and that wasn't the worst part. The worst part is, remember, I went there to get my dose, so I had to wait there 15 minutes. I couldn't leave. Yeah, so, yeah, it's a pleasure to be here. Yeah, the School of Public Health actually gave Vaccine Hunters our first recognition as a pillar of the pandemic, so thank you. And yeah.
So that's great. I think there's, in all these answers, there's an important social element. And I think that thread has really come through because you have science, you have policy, and you have people. And tying them all together appropriately is challenging, but there's other elements we have to consider too. Equity, right? How are you ensuring that that information, that science, that technology, everything gets to the right people and gets to everyone in a way that we can all equally benefit? So with that, I'd like to ask Myrtede and Laura some follow-up questions. Now, both of your research areas focus on vulnerable populations and the social determinants of health. So I'm curious, in the pandemic, what did you see in our healthcare systems that kind of linked to this idea of vulnerable populations and the social determinants of health? What are we lacking in terms of equity, and what can we potentially do to fix this? So I'll start with Myrtede.
So a couple of things. I think the first thing that we notice, and I'll provide some examples, that equity is often an afterthought, and that leads, and I think that directly contributed to some of the disparities that we saw, both in testing and then later in vaccination rates. So I'll give you an example. At the hospital I worked at prior to coming here, to register for testing, you had to use the virtual portal, an online portal. And because of that, there were people who just didn't have access to testing. And so after we realized that, and we got the vaccinations, my hospital was actually one of the preferred sites for the state. And so we got vaccines early. And so, because it was one of the largest health systems in the state of South Carolina. And so recognizing that using this online portal had led to disparities in testing, we had kind of encouraged them to try other methods so that we wouldn't see those same disparities, but it was rolled out in exactly the same way. And lo and behold, we saw huge disparities in the who was getting vaccinated. And so what they ultimately did, several weeks later, was open up a call center that helped improve or reduce the disparities in the vaccination rate. But it was very disappointing to see, right, that we understood these equity and these accessibility concerns, but still they weren't kind of placed at the forefront. And so that's an example of one of the challenges. But the other thing I should note is that the folks who work in the equity space, we already had an idea. We knew that these were some of the issues that were going to come up. And so, we attempted to be more proactive. We attempted to kind of get those seats at the table. We attempted to try to kind of, speak to different leaders in our hospital about how we were going to be proactive in testing, even in rationing, which was a big concern, that I expressed. But part of the issue I think is as Laura and Mohammed mentioned, we didn't always have the right data. I will say, in the U.S., the collection of race data is a bit more robust than it is here. but we don't always have sensitive measures, and we're not always disaggregating some of our outcomes and our processes by race to understand where potential some of these issues exist. And I'm speaking mostly to racial ethnic disparities, but I think similar issues are also going to be a challenge when we think about gender identity and sexual orientation, for example. And so I think those structural barriers in terms of, do we have the data? Is it robust enough? Are we disaggregating it? Are we actually taking actions based on what we're seeing is going to be important to equity. And then I think those are kind of short-term solutions, right? Or I think kind of more accessible solution. I think in the long term, and I'd love to get your thoughts on this, Mohammed, but I think other disciplines have started to recognize race as more of a social construct. And so I think in healthcare, abandoning the idea of race as biology is going to be huge, because we've seen, so many examples of how the use of race as a risk factor, in our medical technologies, for example, in our different algorithms, has disproportionately led to adverse outcomes for marginalized patients. And we saw that in the pandemic. I don't know if that the algorithm, there's one specific algorithm that's used in the ICU about survivability. And it just came out that that algorithm is biased. And so you're making life or death decisions based on an algorithm that biases certain populations. And so those I think are just some of the challenges that we'll need to explore.
Yeah, I'll just follow up a couple, great points brought up. I think any of us that work in the social determinants realm were not surprised at all at the inequities that we saw. COVID didn't create inequities. They just shone a light on inequities that have always been there and that are structural. But what was surprising is how surprised other people were about them. And very early on in the pandemic in this province, there were some very public statements like everybody's at risk. It's not one, when there were calls for race-based data collection, it's not one group or another. Everyone's at risk. This is an infectious disease. And so we did some very early data visualizations on How's My Flattening just to show this, showing area-based income differences and socioeconomic differences, and they were stark, unsurprising to us. And then going forward, that became a staple, and then there actually was new data collection as a result of that. So I think it's just very interesting that it was so surprising at the beginning. I think people now realize, and there are efforts that will persist post-pandemic. But I just want to pick up on how data were used in that, some of the more powerful ways, and this is, I think, some of the more positive learnings from the pandemic, in that it was used to say, okay, now what do we do about these disparities? Not let's try and figure out a new way of accessing it, but let's go to the community and ask them, actually resource them, let them decide what works best for their community, and that was very effective. We saw testing transform once we gave the resources, I say the royal we, but once the government gave resources to community to set up testing locations in their places of worship, in their community where they knew there was trust, for example, that made a huge difference. And then with vaccination, same thing. We saw huge inequities right away. No surprise, but we needed the data to advocate, to say, it's not okay just to have a single portal to sign up. You actually have to have a better vaccine distribution strategy. Again, give it back to the community. They came up with solutions that were so creative, so impactful. So I think that's, again, one of the more positive learnings. We need the data. We need the data to advocate. But this is about solutions that are driven by the community and giving those power and resources back to the community. And I hope we take that lesson beyond COVID as well.
So, Myrtede and Mohammed, I wanted to pick up on that talk about the biased algorithms, and can maybe we talk more about the importance of interdisciplinary research to try to correct those inequities that are sort of built in, and how do we potentially identify and fix? Maybe, Mohammed, we can start with a reaction to Myrtede.
Yeah, it's an incredibly important comment, right? And we've seen papers published around managed care organizations in the United States using algorithms to direct intensities of care to patients that bias against Black people, for example. And there were several articles on this, a lot of media attention. I'm not sure exactly what was done after that, but these are the sorts of things where the danger with these sorts of algorithms is you take a bias that exists, now you have an algorithm that can amplify that bias, and you're kind of left scratching your head thinking, are we actually doing more harm than good? Just a note at my end, a personal story is at our hospital, we have an algorithm that predicts death and ICU transfer among our internal medicine patients. We don't have race data. We don't have data on gender. We have sex data, but not data on gender. We've been able to look at the model performance around things like sickness levels, age, sex, where we have data, but where we don't have good data, we have no idea if there's a bias or not. And so how do you address or correct for a bias when you can't see it? And that's something that keeps us up at night. On the plus side, we're seeing a pretty substantial decrease in mortality after we deployed the algorithm. So we feel like it's saving lives. But what we don't know is which lives is it saving. And that we're really advocating for. We need better data collection on things like race, like gender, like all sorts of other data that we just don't have access to right now.
Thank you. So, Myrtede, when you look at a healthcare system, how do you start identifying points of bias or try to get rid of that? Is there a method, or is it just, when the system's perturbed and then you see it's amplified and that's how you kind of find it? What kind of tools do you usually go to? And is that an interdisciplinary effort as well?
Yeah, I think it will need to be an interdisciplinary effort. I think one area that we start is generally where we know disparities exist kind of on a broader level. So one of the challenges, and Mohammed spoke to it, is we tend to know about disparities at kind of a macro level, right? We know disparities exist. My work is in maternal health disparities. So for example, in the US, we know it exists on the national level. States generally know when they have disparities, but individual health systems within the state might not know that, they're a source of disparities. And so I think that's one area that we start. We say, we understand that, there are disparities in maternal health outcomes. We understand there are disparities in transplants. And so let's try to figure out kind of how our hospital is doing. So that's one way, kind of starting to collect data around known disparities. And then I think finding disparities that within your individual health system is a challenge because you don't have the data on everything. And for some health systems, the capacity to disaggregate data on every single outcome and find statistically significant results is not feasible. Sometimes you just don't have the numbers. And so I think, one of the things that I'm proposing to do with my research is also look at patients' experience. I think, experience is something that, we don't necessarily see as an outcome in and of itself, but for marginalized communities, their experience has huge implications for their health going forward. They might disengage from healthcare systems when they have poor experiences. There's lack of trust, there's lack of treatment adherence, and so these are some of the ways we try to get around it. And so if we start to see poor experiences in certain specialties, in certain areas, that might clue us in to potentially look at the outcomes in those areas. But, in terms of kind of right now, focusing on where we know those disparities exist, trying to collect data in those areas, would probably provides the highest value.
Now, it sounds like a very living thing day to day, having to be engaged with it to make sure it works. That's really cool. So I'd like to change tact a bit and talk about the online experience. So both Andrew and Laura, had a significant online presence, and Andrew with Vaccine Hunters Canada and Laura with How's My Flattening Dashboard. So with that, in your experiences, curious to know, what do you think are the important day-to-day tools or even frameworks that we should have kind of permanently in place to help us the next time something like this happens, and to really help us kind of build more robustness into our healthcare system? And Andrew, I'd like to start with you.
So I would say the centralization of data and services is very important. I say this because over the past year in Vaccine Hunters, we've gotten a chance to work with all the provinces and territories in their vaccine rollout strategies. And I can say that British Columbia and Quebec, with their online portal for all residents, caused us the least headache and work. Most of our work, if I can be candid, it was for Ontario, based on the sheer population, as well as, let's say, the downloading of all responsibility to public health units. And I want to give a shout out to all hospitals and vaccine clinics for being heroes during the pandemic, continuing to protect people every day, even now. And another thing I want to touch on is pharmacies. So they're the big name pharmacies like Shoppers Drug Mart, Rexall, Sobeys, Loblaws, and so on. And there are also the independent pharmacies. And the thing is, with these independent pharmacies, they don't have online portals for people to book vaccine appointments. And sometimes they have to throw out doses because they expire. So one thing to bridge or fill this gap is we developed an open source system called Find Your Immunization, which allowed franchise pharmacies as well as independent pharmacies to enter vaccine appointment availabilities. And I can say that we had a lot of independent pharmacies from across the country use our platform, which was actually accepted as a digital public good by UNICEF, as well as had some, the World Health Organization is aware and supports our platform as well. So bringing back to my overall point is having a centralized vaccine portal where people could pre-register, enter their age, if they're at higher risk to COVID, and either their full postal code or just the first half. I feel that the government could have worked with this data and prioritized people who, for example, say that they had no means of traveling to a vaccine clinic, or a person could submit an entry for their parent and who might be bedridden. And so to make sure that these people are not forgotten or left behind during the whole blur of the last year.
Yeah, for sure. I will just 2 points. One is multidisciplinary teams. Like the idea of us coming together and working on a problem from different perspectives. We all say it, but we don't actually do it very often. But with COVID, we have to do it. So with How's My Flattening, the two co-leads, Ali Asensoy and Ben Fine, are engineers, right? Ali's alumni of U of T. And there's absolutely, and I'm an epidemiologist, I know a lot about epidemiology. I know nothing about setting up a dashboard that needs to be dynamic and virtual. And I learned a lot, and now I know a lot more. But the idea that we have to start getting comfortable with bringing in this expertise, a lot of volunteers, and working together on big societal problems, I hope that's something that does. And we create silos all over the place, including in universities and all of our settings. And so I hope we break some of those down. That needs to continue. None of these projects would have happened without that. And the second one relates a little bit also to another collaboration. I'm working with Professor Burson Domnez and Myrtede on human factors, bringing human factors to a lot of the analytic work we do. And so again, that idea of I can be an expert in one piece and the analysis and the interpretation and the public health understanding, but not in who needs to use this data tool that we're developing, what do they need to do with it? And I think that was something for a lot of the data elements that we created during the pandemic that we could have done a lot better. And hopefully with these types of collaborations, we will do a better job at that.
So I'd like to pick up on that. There seems to be a lot of usability challenges that come into this. And that kind of segues nicely into our next question is for Myrtede and Mohammed. During the pandemic, the number of virtual doctor and emergency room visits, just the frequency increased tremendously. And going forward, a lot of people are wondering, will virtual visits be a permanent staple in the future of healthcare? And if it is there a role potentially for AI to help make patient management better? We already know that there's some risks with AI in general for biasing, and we want to absolutely prevent that if that's the case. But what are your thoughts? So I'll start with Myrtede.
Yeah, I think it is absolutely here to stay, and I think that's good. I think it's a net positive. I think when it comes to virtual health and telehealth, we haven't necessarily realized all the benefits in terms of accessibility that we potentially hoped for because of the digital divide, potentially poor connectivity and broadband in some of the more rural areas. And so in that way, I think sometimes the people who would benefit from it the most don't necessarily have access to it, along with different privacy concerns. And I know in the U.S., for example, there's a large population who only use internet on their phone, right? And so those platforms aren't necessarily optimized for more mobile phone use. But overall, I do think it's hugely valuable, and we saw it during the pandemic. Even though some specialties I think picked it up a little less smoothly than others, it was a net benefit. In terms of AI and big data, I think I've become a bit of a Luddite when it comes to AI and big data use in healthcare for some of the reasons that we outlined. I think healthcare tends to be slow adopters, and I think there are some benefits to that, right? You see how things work in other industries and other domains that are, I think, less critical, right? And so we're, with AI, we're seeing the challenges that Google had. We're seeing, Facebook or Meta have challenges. We saw IBM abandon their AI facial recognition program. So we're seeing all these challenges in AI. There's work now trying to figure out how do we debias algorithms. My preference would be to limit as much bias into these algorithms versus trying to kind of do debiasing on the back end. But I think because of these challenges and other challenges we see in big data, Mohammed mentioned, we have a bias towards the data we collect where we don't necessarily recognize that it doesn't show us the full picture. And so we think we have all this data and we act on this data, and it can exacerbate, these disparities. It can create technology-induced disparities. And so, yeah, I tend to get a little skeptical and a little cautious when it comes to AI and big data. But I think eventually it will be valuable. And I think there are probably parts of healthcare that don't focus necessarily on managing or treating patients, where AI, where any issues with AI are potentially less harmful that we can kind of implement.
So Mohammed?
Yeah, these are great points. I think as far as virtual care and the emerge visits and all that sort of stuff go, I think virtual care it's here to a certain extent to stay. And I think it's only going to get better over time. That's the hope. What we're not really sure about is how well it really works. I think there's more and more information coming out there, like for example, our emergency departments are swamped now. And one of the thoughts has been is we've done so much virtual care, people have kind of pushed their more serious conditions instead of seeing a physician right away or anytime soon, they actually let it build up. And now our emergency departments are really full. And if I go back to way back when I used to do clinical work, it's kind of important to actually see a patient, and when you're talking to them, kind of see the finger twitch and say, maybe there's something neurological here that we need to investigate more. I'm not going to see that when I'm just on a Zoom call with the patient. So you're going to miss a lot of these things. So it's not going to be a panacea for everything. I think there's going to be a healthy balance between what can be handled virtually and what can't. I don't think we figured it out yet. One of the benefits of virtualization, virtual care, is it forces us to be more digital. And it forces the data to be more digital. So keep in mind, healthcare is still in the era of fax machines and paper and such. A lot of hospitals are not completely electronic. But what this virtualization is forcing us to do is to collect data in a format that can be amenable to analytics and AI and such. And just a point on the AI stuff, so I have a team, my team let me know last week that we've deployed over 40 solutions leveraging techniques like AI into clinical practice. Some have been successful, some have not been so successful. But I do think it fundamentally does affect or can affect how we operate. So for example, one of the things that you think about when you're in a hospital is who are the patients that I don't need to worry about as much, who are the patients that I really need to worry about, and who are the patients that are in between. We are awful at allocating that sort of risk because clinicians really struggle, and there's paper after paper showing how bad we are at it. When you have a tool that can help you do that, it can help you allocate resources much more effectively and efficiently, so you pay attention where you need to pay attention at the right time. And I think that's the potential for AI to be able to transform how we deliver care to patients, along with all sorts of other applications. So I'm a little bit more bullish on AI because we've seen the effects of it. That being said, we're also very careful about the projects we do take on versus we don't, because there are issues with taking on the projects that you know are going to fail, that may cause more harm than good, as has been alluded to. But also the thoughtfulness around when you deploy something, it's not just a cute research project. That model will degrade. The data will shift. And are you monitoring things continuously for the next few years? And you're responsible for it's a pretty significant investment in time and energy.
It's a really interesting point. The challenge of virtual care, amplifying inequities to begin with, but then also really benefiting certain populations. And for the patients that it leaves behind, it may be difficult to express that they've been left behind. So we might be losing a lot. That's a really important thing. And the data collection is actually very interesting because forcing the healthcare system to be more digital can be quite interesting. That is a good point to pick up maybe with Andrew. Both Mohammed and Andrew use data that came from very different sources. So Andrew, you spent a lot of time with your team scraping data from the internet, but also crowdsourcing. You mentioned the power of volunteers. That's fantastic. Contrast that with Mohammed, who had actual hospital data to work with. So my question to the two of you is, going forward, these two kind of streams of data, do you expect that they will remain separate, or is there a way at some point will they start integrating? And if anything, in that integration, how do we make sure that what comes out of it is meaningful can someone like me read it and understand and get something useful out of it, or is it going to need somebody who's very technically trained and have a lot of experience in a certain area to get anything out of it? Like coding in R versus using a GUI or something like that. So, Andrew, what are your thoughts on where data comes from and perhaps on how they can be integrated?
Thanks for the question. I would say data or information is power. So I worked a lot with my team on vaccine availability. And vaccines were the hot item over the past year. High demand, low supply in the early days. So you can liken them to like a PlayStation 5. So yes, information is power, and it's very important that this information is shared in an open manner with the public. So we try to do that through Twitter and other social media platforms, as well as in real time on our chat server. And the importance of making this data available to everyone is so important. One example is my grade 10 English teacher from 18 years ago saw me in the news and sent me an email saying that her 95-year-old mother was bedridden, has cancer. They were looking for a third dose. And so I sent some resources on homebound vaccinations. And she emailed me a couple weeks later saying that a nurse came to their apartment and vaccinated her mom. So that was a big story. But one thing that stuck out is in her email she said, "I feel so lucky." And I just remember those words because no one should be feeling lucky to receive health care, especially by the time this was in December, so just a couple months ago. So in the third dose rollout. So if we can use AI and big data to ensure we lift everyone, those who are marginalized, those who can't travel to a vaccine clinic or to a doctor's office or hospital, and just make sure that everyone has equal access.
Mohammed?
Yeah, I think the issue of different data sources coming together, I'm kind of lazy. I mean, I like the hospital environment because the patients are pretty much captive, right? You've got them in between, within the four walls. So all their labs, their vitals, their orders, all that stuff is collected in a contained environment. Of course, then we struggle when we say, well, okay, how many patients are really getting in? That's dependent on what's happening outside our four walls. And do we have a really good handle on things like vaccination rates? Do we have a good handle on upcoming policies or legislation or whatever have you that's going to change that will necessitate a lockdown or that will have school closures or whatever have you, because that will affect infectivity, that will affect how many patients we see. And when we look at the outside world, we say there's a lot of data there, but there's so many gaps and patches that it's hard to know what to do with it, where and how to integrate it into our hospital setting. So there's some that can be done, but probably not as much as people would like or think. And that's what we struggle with. Where is that intersection to make that data useful? Because it has to be timely, it has to be high quality, it has to be comprehensive, and we don't have that. The other thing, just to give you an example, people say, well, we have these suggestions. There are these apps out there. Why don't you use data from these apps? First of all, how do we get data from the apps? There's all sorts of issues we have to go with. Secondly, what's the dropout rate? most apps, 90% of your users will drop out after a couple of times of using the app. So now you've actually got data on that 5% that may actually be biased to Myrtede's point. Now you're even worse in the problem if you use that data. So all sorts of issues, a lot of potential, but a lot of challenges.
Seems like part of the problem is that there's no universal platform to get information out to anybody, right? And it seems like you need multiple routes to disseminate information, right? And that goes back to your point, Laura, about the importance of interdisciplinary teams, not just on implementing solutions, but also communicating it too. I think that was one of the big challenges that I saw myself in the pandemic, this breakdown of communication, where science is, very well vetted, but the communication of it to everyone else, breaks down as the message gets shorter and shorter, and you lose a lot of important context. And that could be explained in 2 minutes, but you only have 10 seconds. So this is, a universal problem I think we're kind of hitting up against. And the people who have access to extra time and bandwidth to see this, again, may not be in every community. So those inequities kind of pop up, and that's some challenges. Now we do have time for one quick audience question. I think we should take a look at that. Okay, so one of the questions is, I'm curious about how you collect data where location and demographic data is recorded at vaccination sites and testing. Any input on that?
Maybe I'll start. So we do not generally, so the data are not linked together, unlike what people might think. Like you might think going to get tested, obviously they have my demographic information, that's flowing to that thing and that thing and the thing. That's not how things are set up. So a lot of ad hoc data collection needed to be set up during the pandemic, and then it wasn't integrated very well. So that's a huge challenge. There's been lots of efforts, for example, to try and get some of that information onto your health card number. So at least there's a central place where all of these other contextual information exists. And then they take with other information they know about you, like the postal code and like some area-based measures. So that data infrastructure currently does not exist. Going back to Andrew's point about that it doesn't exist nationally. Every province does it differently. We have no ability to look at these questions and use data at the national level. So there's a lot of holes in how this is not ideally set up. People are now talking about how we set up for the future. A lot of ad hoc, disconnected data collection.
Okay, thank you, Laura. So let's wrap up quickly with one take-home message from each of our panelists. So start at the end, Myrtede, one take-home message.
So I think one thing that Laura, I think one thing that can be kind of taken away from this panel is the need, you had a question about the need for interdisciplinary research. And so I think engineers have been a little late to the game, but we need, social scientists, we need engineers, we need public health and epidemiologists, we need obviously our clinician collaborators, we need volunteers. And so this is a big nebulous problem that's not discipline specific. And so I think there are opportunities for every discipline to provide, expertise and a vantage point that I think supports how we provide better, safer, more accessible and equitable healthcare.
Andrew?
I would say always try to look for opportunities to help others. So realizing that Vaccine Times Canada was mainly online and catered to people who were able to use technology or who are tech savvy. One of our, marketing campaigns was be the hunter in your family and help out your parents or grandparents. And I realized just now that this slogan would have freaked my vaccinator out so much.
I'll just say resist the urge. There's a very strong pull to just go back. It's like the pandemic's gonna be over, let's take a deep breath and go back to the way things were. We have obviously learned that a lot of things are broken in our system, And so use the skills and energy that you have to actually make some changes in a positive direction. Let's do better. We have an opportunity now to build that really resist virus to go back, and we're all well positioned to do that in the skills that we have and working with each other.
Okay, I think for me, it's aim for perfection, but work with imperfection. So we always want the ideal environment. We're never going to be in the ideal environment. So it's good to aspire to that, but have a really realistic view on what is available, what can be done, and a very thoughtful approach in terms of how you leverage the current environment to be able to benefit the situation you're in now.
Maybe I'll share a personal take home for me. I found that masks with ear loops actually bend my ears very easily. My 1-year-old discovered this, and this is now a toy. So we have to think about masks too. Anyway, this has been a phenomenal panel. I really enjoyed moderating this with all of you. Thank you so much for sharing your time, and I hope you all enjoyed, and hope to see you at the next one. Thank you.